Dr. Eron Friedlaender is clinical pediatrics at the University of Pennsylvania and attending physician at the Children's Hospital of Philadelphia. And without further ado, I'd like to formally introduce Dr. Eron Friedlander, who specializes in the care of youth with autism in hospital settings and leads research-driven clinical programs to improve outcomes for children with social and developmental differences. Dr. Friedlander serves on the Institute for Human-Centered Design Board, contributes to the First Place Translational Research Consortium, and consults on neuro-inclusive design for healthcare environments. Most importantly, she is the mother of 3, including an autistic son, and cherishes the beautiful relationship he shares with his sisters. Welcome, Dr. Eron Friedlander.
Thank you so much, Josh. It's a genuine privilege to be here with all of you today, and I'm really excited to share a bit about my experiences and work to support autistic individuals in healthcare environments. As Josh said, most importantly, I'm a mother, and you can see my son Alexander here, who is autistic, and everything I do comes from a place of wanting an easier way forward for him. I'm also, as he said, a pediatric emergency medicine physician at Children's Hospital of Philadelphia, which we call CHOP, and I care for many autistic patients there, both in behavior crisis and for routine pediatric illnesses and injuries. And I'm a public health investigator and work in partnership with a number of architecture and design firms to embed evaluative methodologies for inclusion in different environments, including university campuses, museums, playgrounds, and hospitals. This is an X-ray of Alexander's elbow. When he was 6 years old, he fell and needed an emergent middle-of-the-night operation to repair this open supracondylar fracture. Unknowingly at the time, the surgeon accidentally severed one of the 3 major nerves in his arm during the procedure. Multiple times over his recovery, Alexander tried to explain to his doctor that his hand was different. He didn't cry, and he didn't act out, and he didn't perseverate. He used calm and gentle language to try to talk about how his hand felt different. But every time he started a conversation, the doctor would pat him on the head and sort of stroke his cheek very sweetly and tell him everything was fine, but never actually examined him or engaged in a conversation. And 8 weeks later, it was a visiting fellow studying at CHOP who actually sat down in front of Alexander and in moments was able to see the catastrophic damage that required additional operations and castings to try and recover the motor function he had lost from this. And I wonder, and at many times I've been quite certain, that his label of autism felt a specific challenge to his care team simply with a word, and it limited their engagement. And so I come to this talk and this work as a mother first. Here is a piece of a several-page document prepared hastily out of desperation by the mother of an autistic patient named Julian, who came to the emergency department needing a procedure. Mom couldn't be there, and she sent her husband, Scott, with these pages of instructions for us. And these kinds of communications are so very helpful to us, but are often not available, especially when people are coming to the emergency department unexpectedly and in crisis and scared. And oftentimes these are pleas for specific care approaches that many providers feel are either too laborious or not their responsibility to follow. And I'm sorry about that. They're often really difficult to maintain as something that people can keep with them because medications are adjusted so frequently, and things that kids find favorable or as desired rewards to support compliance evolve so frequently that it's really hard to keep this level of engagement up. In September of 2023, the National Institute on Minority Health and Health Disparities formally designated individuals with disabilities, including autism, as a population experiencing healthcare disparities, and thus elevating care delivery as a priority for NIH research. This was so important given the large literature base detailing the poor healthcare and outcomes of autistic patients. And having just returned from the Autism Europe conference in Dublin this past week, I can report that this is a priority and concern globally among autistic individuals and their advocates. Some of the themes that run through this literature base and that I see in my own practice quite frequently relate to lack of capacity within all domains of adult medicine to care for autistic patients, the numerous barriers within healthcare systems for those with executive function vulnerabilities and sensory sensitivities. And for me, most distressing is the frequent reporting of poor relationships and interactions with healthcare staff. So now I'm going to try to quickly introduce you to some of my recent patients to help ground this conversation for us. The first patient is Kevin. He's 17 and he was autistic and nonverbal. And he came by ambulance to the emergency department because his staff felt that he was walking a little bit differently. He was kind of shuffling and hunched over and seemed uncomfortable. And he came with a binder, which is frequent. He didn't have any staff from his facility with him, and he didn't have a parent with him. And they basically suggested that we try to communicate with him using computer. And that's not always an easy thing to do when you're uncomfortable and not feeling well. So I spent some time with Kevin trying to get to know him and understand where he was struggling. And it was quickly easy to find that there was a problem in his belly. And in this next slide, you can see that he had what we found was a perforated gastric ulcer, a highly uncommon finding in a 17-year-old. This is an illness of largely middle-aged and older individuals. And this is a complication and illness that takes time to develop, like months or years. And so Kevin suffered a really long time without being identified. It happened that the next patient I wanted to speak about is another Kevin. And this Kevin was 14 and had a very complex history, including profound IDD and epilepsy. And he came with his mom after being at what we call an outside hospital, another facility prior to us, because mom was concerned about him looking uncomfortable when he was breathing. They actually were seen by a pulmonologist and a full ED team and diagnosed with constipation, which is unfortunately a frequent go-to diagnosis for many autistic patients that come acting out. And mom was concerned that something was being missed and that he hadn't had a thorough looking over, so he came to us. And it was clear from just looking at Kevin and looking at his vital signs that something was still undiscovered. And on a chest x-ray, which was perhaps done within a very short period of time, on the next slide, you can see that he had a complete collapse of his right lung called a pneumothorax, and all of the structures of what we call the mediastinum, which is the heart and all of the big vessels around it, had been shifted in a dangerous way. This is a catastrophic and life-threatening condition, and it universally causes pain, air hunger, and distress in those who are able to describe their symptoms. Healthcare service use by individuals with autism has been well described, and all of the published studies have very similar conclusions, so we've got some thematic saturation here. And as you can see here, and in many other similar studies, we see that autistic patients commonly present to emergency departments for simple primary care concerns, often for mental health care concerns, and for seizures. Autistic patients have higher medical expenses overall, greater rates of hospitalization, and frequent revisits compared to the general population. There is a fair amount of room for our health systems to better meet the needs of autistic individuals. ED utilization and IDD. So all of these kinds of values are amplified for those who come with comorbid intellectual disability. Importantly, the emergency department has become overwhelmed by the numbers of autistic children and adults in crisis needing mental health care. We know that in general, mental health care is an area where we need to build capacity, but within that, the numbers of people who have autism presenting with need for better integrated behavioral health services has really risen. So our report card doesn't look so good as a medical system. Doesn't seem that we're serving autistic patients as well as we could be. And I don't think we're serving them as well as we want to. I made this list of frequent clinical blind spots to help draw attention to knowledge gaps as one approach to strengthening healthcare systems for autistic patients. I focused on this specifically for today's discussion, but believe there are many layers of change that will ideally come together to improve healthcare access and delivery. Very soon, this conversation will center on exciting ways to close some of the knowledge gaps and introduce the means to strengthen the collective skill set of medical teams caring for autistic patients. So perhaps as an example, this was Dee. She was a little 6-year-old who came in because she had intractable vomiting. She had profound intellectual disability. Her parents chose, though, not to disclose her history of pica because of fear of stigma, which they later shared with me. Pica is a condition where you eat non-food items. And while I was talking to the parents, Dee was happily munching on crayons. So it was clear that this was a behavior of hers, and it made it quite easy to think about the fact that she was likely vomiting because she had an obstruction from something she had ingested. And on X-ray, which you can see here, there's a large concretion of paper and foam. She was eating the foam out of the cushions of the sofa in her belly, and that was causing the vomiting. And whether it was stigma that held back an earlier diagnosis, because this takes weeks to months to develop, or that no one knew to explore her behaviors, Dee went undiagnosed for so long she too needed an operation. This 5-year-old boy came to the emergency department with a limp, and that's a very common complaint for us to assess. But following an exhaustive and extensive evaluation, an MRI finally demonstrated bone marrow changes consistent with scurvy, which is vitamin C deficiency. And an MRI in a 5-year-old is a bit of an undertaking. You need general anesthesia for that to be able to sit. So we have gone really deep down a evaluative process for him. And a diet history in a child with a recognized limited number of preferred foods would have quickly directed this evaluation much sooner and much faster, with much less time, discomfort, and cost. And then finally, there was John. And I highlight here that John was able to communicate pain, and he presented in a highly toxic state from a missed ruptured appendix that had caused extensive infection within his belly by the time I got to see him. Appendicitis is often a very straightforward assessment that evolves over 1 to 2 days before it ruptures. John's degree of illness meant unrecognized disease for an uncomfortable length of time. So my study here is one of others documenting that autistic patients with appendicitis have much later diagnoses, which translates into complicated disease with significant morbidity, more often than in neurotypical peers. And it's one of many ways in which this population is vulnerable within medical systems. We have many opportunities here. Our evidence-based and recommendations must grow. Limitations of access to and receipt of care extend from at times aggressive or externalizing behaviors, unfamiliar means of communication, and staff inexperience or discomfort finding flexibility within structured care practices to accommodate anxiety, developmental delay, intellectual disability, or sensory meltdowns. Consequentially, this results in incomplete procedures, restraint, delayed presentations, missed appointments, and foregone care. Interventions have focused on providing more visit preparation and support, modifying environmental demands, and provider awareness. Currently, there is a lack of outcome measures to support broader application of the pilot programs that we've reviewed for this paper. And in this recent scoping review, we investigated interventions designed to optimize care of people with autism in healthcare settings and found a very large number of articles needed to be excluded because of the lack of rigorous scientific methodology applied to the patient populations. In fact, we looked at 8,000 abstracts and articles, and we're only able to comment on about 30 of them that had methodology that was worth amplifying the diagnoses of. So I am going to end by sharing this one slide. So I've participated in a large number of projects related to building better systems of care for autistic patients. And I wanted to end on this high note here with this initiative at CHOP, where we uncovered a feasible and meaningful improvement of care when clinical event debriefing occurred with behavioral health specialists embedded within care teams. And I invite anybody to reach out and have a conversation or share ideas or brainstorm or emote. I'm always available. Thank you so much for being here.
And thank you so much for Dr. Friedlander for the way that you lead and the personal stock that you have in the quality care of individuals with autism.